Welcome, everyone. We are excited to have you all in attendance joining us for this evening's webinar, Enriching Your Practice with Autologous Orthobiologics, Applications for Modern Interventional Pain Management. Tonight, we're very fortunate to have four esteemed guests on our panel, Dr. Jason Dragoo, Dr. Bert Mandelbaum, Dr. Ashu Goyle, and Dr. Ariana DeMers. They will discuss traditional procedures for lower back pain, transitioning into the innovative approach of platelet-rich plasma. What is protein concentrate and how is it revolutionizing treatment of acute and chronic pain, and tackling the benefits and challenges of cash pay practices, all of which will be followed by a Q&A session at the end. To allow for the most interactive and productive experience for you possible, please load all of your questions in the Q&A chat box at the bottom of your screen. So we welcome Dr. Jason Dragoo, who's the professor and vice chair of the academic affairs for the CU Department of Orthopedics and a now chair of regenerative medicine. He has developed many procedures designed to augment the healing of patients' own body, is the head team physician for the Denver Nuggets, as well as consulting physician for the U.S. ski team. A significant number of Dr. Dragoo's patients are elite athletes, but he welcomes athletic patients of all ages and treats them with the same philosophy and surgical or non-surgical techniques. Dr. Bert Mandelbaum is a leading orthopedic expert who graduated from Washington University Medical School, completed his residency at Johns Hopkins Hospital, and now works for the Cedars-Sinai Kerlan-Jobe Institute, affiliated with UCLA. Dr. Mandelbaum is widely recognized for his research and sports medicine contributions. He's served as the team physician for UCLA Athletics and the LA Galaxy, as well as played vital roles in FIFA World Cups and Olympic Games. Dr. Ashu Goyle is a distinctive double board certified physician in both anesthesiology and interventional pain management with a fellowship in pain medicine from the Cleveland Clinic. Dr. Goyle has been recognized for outstanding patient care during his residency and has a strong background in both acute and chronic pain management. He's an active member of several professional organizations, including the American Society of Anesthesiologists and the Institute for Functional Medicine. Last but certainly not least, Dr. Ariana DeMers is a board certified and fellowship trained orthopedic sports medicine surgeon. She previously served as president and board member of the Interventional Orthobiologics Foundation and is recognized as a prominent educator and trainer in orthobiologics and ultrasound. Dr. DeMers has successfully transitioned her rural practice away from commercial insurance, emphasizing a holistic approach to orthopedics. So without further ado, we would like to kick off the presentation and pass the time to Dr. Jason Dragoo.
Well, good evening, everyone. Great to be here, and I will bring up my slides here in 1 second, and we'll get started on something that I think will really is an exciting advance. And I think that the host has to give me control to put my slides up, and it says that the host has disabled participant screen sharing. Great. All right, here we go. All right, now we're ready to go. So this is Jason Dragoo here, and I am in orthopedic surgery. I spend a lot of time really in the basic science and really trying to evolve biologics for many years. I serve as the science officer here for Apex Biologics, and I wanted to talk to you guys tonight about some scientific advancements that I think are really exciting. And regardless of where you're practicing medicine and what type of subspecialty, there are benefits of these type of biologics that can be beneficial to any type of practitioner. I think most of you are aware, of course, of platelet-rich plasma and how things have really progressed with PRP, and then at the same time maybe recognizing that platelet-poor plasma was the waste product, right, of PRP production. This is the substance that we used to throw out when we concentrated our PRP. And then as time has gone by and science has progressed, we've learned that there's a lot in this platelet-poor plasma that we can harvest. And so then it was up to really getting the machinery or the devices to the capacity to be able to pull in these beneficial factors and we're here. Some applications of this, and we'll talk about this, I think, a little bit later, including muscle regeneration and muscle injuries, etc. Also, the treatment of effusions and inflammation in the body. So that's the angle here of the use of PRP, the previous waste product of PRP. So here's a little science here tonight. And I just want to show you really how we started doing this. The approach of this project was to measure our ability to concentrate factors within the plasma. And Apex has developed a different type of technology of a plasma filter. So devices on the market are routinely at the 65 kilodalton pore size. So therefore, it can really filter out big molecules and factors within our blood and plasma, but not the small ones. And so this is really the new technology that Apex has, is this very small size. And I'll show you in a second how this really is beneficial. But even in the chart below, you see HUM, we'll talk about that. It's giant, right? So really any of these filter systems can filter that. But when you get down to the real beneficial factors that are smaller, then this pore size can be very beneficial. And again, I just want to share with you the science of that here today. So the way we really can tell what's going on with these filter systems is by using a single patient's blood and the products from a single patient's blood. So we took 10 healthy donors, and we took 120 cc's of blood, and we split it with the new generation plasma filters and the old generation filters. We did a lot of analysis, including whole blood, including making PRP from each of the patient's blood, platelet poor plasma. And we also looked at the waste products of our filter system, just to see if we're missing anything, and some of these beneficial factors were going out in the wastewater. So one of the first things that we saw is that these new generation filters tend to concentrate the plasma essentially double to the marketplace. And so here we see under the water extracted, every patient is treated in the same way. We get the same amount of overall cc's from our initial blood draw. And then with that, how much water can we take out? How much can we extract? And you see that the Apex is able to take out much more of the water and concentrate then this protein concentrate in a much more viscous, concentrated way. And what you see overall from this chart is that it's roughly double, right? So we're starting with how much water extracted, and we see that it's 20 cc's. The marketplace is roughly 10. And the protein concentrate yield then is half, because it's twice as concentrated. And when we're doing injection therapy, and I think you guys do a lot of this, there are many sites of injection where it's not possible to have a lot of a lot of cc's of injectate. You just can use 1 or 2 cc's in some areas of the body. So having a more viscous concentrated solution may be beneficial. With that double of the concentration, we have double roughly of the platelets. And although maybe many of us would not be using the plasma filters for platelets, right? We would make PRP for that. At the same time, we're able to capture a lot of the residual platelets within the plasma using these devices. And again, the Apex, because of its pore size and concentration effects, can roughly double the current marketplace other filters. And this shows, again, just the slide that we can capture more platelets with our device, but it is because we're concentrating the fluid more. We're taking out more water, and so therefore less mLs, and therefore more concentrated platelets. Well, here's really the big thing that I want to talk about tonight, and this is what are we really trying to capture out of platelet poor plasma? And the upper part of the chart are the larger molecules, right? And many of these are beneficial, but we're going to talk about A2M of being something that's really beneficial for many of our patients. And, that's something that's easily achievable with the 65 kilodalton filters. But below the red line, those things were previously not achievable, right? Because these factors, as you can see with their molecular weight, are much smaller. So then can this be beneficial? Can these smaller pore filters, can we actually concentrate these beneficial molecules? And I think the answer is clearly yes. And that's what I'm going to show you on the next slides. So let's start with A2M. And for those of you who are not familiar with it, this is something that's used in biologics more and more often because it's a very potent anti-inflammatory agent. It actually works as a protease inhibitor, and you can see it just kind of locks up proteases. And so therefore it neutralizes them. And then the more of the A2M that's circulating around, the more of these metalloproteinases and other proteases are inhibited. Therefore, it in turn has significant anti-inflammatory effects. And that's what we see really from the patient, from the clinical side. So if you look at this chart here, you see that A2M is present in whole blood and PRP and platelet-poor plasma, but it's in not a significant enough concentration to be effective. So it really does take a filter system to be able to really concentrate this in clinical amounts that would matter. And so you see both the market and the Apex fluid concentrators do a good job of concentrating A2M because it's really big, and they should do a good job with that. But even with comparing the two, we see that over a 1 times higher amount of concentration with Apex. And again, it's because of our concentrating capacity. So pretty exciting with regard to A2M. I might also know with A2M that many times also there are other systems that concentrate A2M, but they're expensive and they take a long time to machine, right? They take a lot of blood to be able to have enough of the A2M that's concentrated. And so this is a big change from that, right? Because this is very quick to concentrate. The A2M with much less volume. So a big improvement as far as our ability to concentrate A2M. Well, we've heard a lot about this from Europe, right? IL-1RA, and there's many products, biologic products in Europe that have been approved in the EU to really help with IL-1 mitigation, right? And so we know IL-1 is a potent inflammatory mediator. So this receptor antagonist neutralizes it. And you can see in the diagram here, it's the receptor antagonist is it's like IL-1, but it's a dummy. And so when it goes into the receptor, it does not lead to a signaling cascade of inflammation. And so the more of this that is present in the plasma, the more that we can block these receptors and therefore eliminate the effects of any circulating IL-1. So that's how it works. But in the same way, we need a lot of this IL-1RA to work to make sure that we satiate all these receptors to have a clinical effect. And if you look at the data shows that we need kind of 100 times more, right? 100 components of IL-1RA compared to 1 of the IL-1, right? And then we can get some pretty good anti-inflammatory effects. So then the question is, well, can we achieve that with this filter system? And the answer is yes. And again, this is really good. This is the science that we wanted from this. This is the performance we wanted because, again, the pore size, these are very small molecules. Going back, this is 24 kilodalton. So this wasn't possible previously. And so what we see this with the different filter sizes, again, you can see the difference in filtration and the concentration of the IL-1RA. And again, this is the first time that in the United States that we could do this. And so then this is just yet another thing that comes out of this platelet poor plasma concentrate. And we found that the ratios that we can get from this filter concentration is around 101 and sorry, 100 to 1. And that's what we've really seen with previous articles that show clinically significant effects. So again, a huge new thing that we have that we can concentrate for the first time here in the United States. Very similar to this is soluble TNF receptors. This works a little bit different than the IL-1RA, but what is the same is that tumor necrosis factor is one of our main inflammatory cytokines. And these soluble factors are a little different because they float around and they float around in the plasma, and then they can gobble up this TNF. And so you see that they're attached to these soluble fragments, but the soluble fragments don't attach to the cell. And so then they're kind of wasted. And then the active receptors that are attached to the cell, there's less of the TNF that can activate it. So again, the more of these soluble units that we have, the less of a chance that TNF is going to be an inflammatory agent in our particular patient. Once again, the soluble receptors are very small, at around 25 or so kilodalton. So again, are only the really smaller filters, pore size, are able to achieve this. And you can see from the graphs here how much more we're able to achieve the concentration of these soluble factors. And so therefore, again, this is yet another method of anti-inflammatory use of our platelet-poor plasma. We have A2M, we have IL-1RA, and then the soluble TNF receptors here. So this is really the trifecta so far of decreasing inflammation by the use and the concentration of platelet-poor plasma. So, well, that's only part of this, but the other is really trying to establish, and we're doing more and more research to try and understand how we could make these injections that we give our patients, how can we make them last? And, you know, if we take out some active inflammatory cytokines, that's great. It's the here and the now. But my question to you guys is, well, what about 2 months from now? What about 6 months down the road? Are we going to have any lasting effects of our biologic injections that we're giving our patients? So to that end, there are some things that are in our plasma that are beneficial longer term. And one of these is the platelet-derived growth factor. And there's 3 forms of this growth factor, but this fraction BB is really showing to be really the most significant part of this. And the reason is because these mesenchymal cells that we're chasing, that we want to activate in our local tissue niche, are hanging out on the sides of our blood vessels. And they're there, theoretically, to be able to react to the local environment. And if this blood vessel is disrupted by injury, then these can be mobilized. But if the vessel is not destroyed, then how can we release these mesenchymal cells to come in to the tissue environment to help regulate? And the answer is one of the main factors is the platelet-derived growth factor BB. And so therefore it leads to activation of the local stem cell niche, so to speak, or the mesenchymal cell niche. And so therefore, if those cells are then activated, they're coming into the area of need, then they can help regulate this over a longer period of time. So this is also the benefit of activating and concentrating the platelet-derived growth factor. And as we can see, most of the platelet-derived growth factor is in the platelet fraction, right? So platelet derived, and so then PRP is very enriched in this. And this is something that we're working at Apex to even further enrich this in our PRP samples. But also the question then was, well, if we really want to have a lot of this, we really want to activate the local cells, can we also capture this in the platelet-poor plasma? And you can see that the answer is yes. And we have a 2-fold increase compared to the standard filters. But we are able to get significant amount of this platelet-derived growth factor from even the platelet poor fraction. And so those of you who like to combine and to concentrate things such as PRP and then also a concentrated amount of platelet poor plasma, we're even going to be able to give more of the platelet-derived growth factors in your injection. And then, of course, as we talked about, our next step is really concentrating our PRP and making our PRP supercharged very deliberately with certain factors. And one of these will likely be platelet-derived growth factor concentration. Epidermal growth factor. So any of you who do plastics surgery and things like that, as well as intervene in burn patients, etc., you may be more interested in epidermal growth factor. Certainly for me in orthopedics, we don't really know how we can harness the potential of this very small molecule. So for me, from the science, I was interested that we try to concentrate it to actually just test our filter. Just see, can we even do it? Because our filter size is bigger than this, right? So then, can we trap these really, really small proteins? And the answer is yes, which I thought was really cool, just a measure of our technology. So maybe in the future, we'll know more of the biologic applications or the medical applications of epidermal growth factor, certainly in skin and, quite possibly cosmetics, but certainly, again, in treatment of the epidermal layers, this can be beneficial. But as of now, I wanted to show you the science behind it just because, again, of the ability of these filters to work for very small molecules. One of the other things that we wanted to do is we wanted also to test the efficiency of these filters because we want to make sure that if it's 15 kilodalton, that we're not missing some things and they're floating out in the water. So what we did is we primed it, we concentrated the platelet poor plasma, and then we tested the water just to see what's there. And what we see with this is, again, soluble receptors, something really small, such as 25, 26 kilodalton. There was nothing left in the water after the apex filtration. And in the bigger pore size, no surprise that it didn't concentrate. The pores are too big. And so you see this really clear delineation of what's in the wastewater of the apex devices versus the standard pore sizes. And again, IO1RA concentration, and again, small molecules. And you can see how, again, more of the IO1RA was in the wastewater of the predicates versus the apex. So again, just a sign of the technology. So here's the summary slide of the platelet, sorry, not the platelet, but the platelet pore concentrate. And you just see in comparison to the science of the standard, there's more platelets and there's kind of more of everything. And it has to do, again, with the pore size and the concentration effects. So this, I think, is really going to be a big thing where this is undergoing now a lot of clinical use, so we can really see which type of patients and in what applications is this going to be most efficient for our patients. So thank you. That's why I wanted to share with you guys today. Because of another webinar, I'm going to have to log off, and I'll stop sharing my screen so we can have Bert Mandelbaum get ready for his slides. But if there's any questions, happy to have them before logging off.
Thank you so much, Dr. Dragoo. We really appreciate your wonderful insight on this data and these revolutionary treatments. We would like to now pass the time over to Dr. Mandelbaum.
Well, great to be here, Jason. And as always, Jason has been my partner in crime over the last years in the world of orthobiologics. And what's most fascinating is really just a few years ago, we were all asking ourselves the question about what does HA do? What is PRP? How does it do it? And now Jason is in his very precise understanding of every component part of what's in PRP, what's in PPP, how do we get there? How do we concentrate? What the size? The amount of precision detail right now that we're learning and Jason really exchanged with you is so important, because it's really created this amazing compendium of science that we're about to really uncover over time. So everybody see my slides?
Yep.
Good. So my talk is really about to talk about orthobiologics, and again, coupled with Jason's talk of understanding how we think about mining and the whole concept of what is in our blood, why is it there, how does it work, and how do we utilize these interventions to focus on the diagnosis of and opportunities when it comes to osteoarthritis. And that's really what I'm talking about today. So I'm going to just really get off to the start of this is really I'm a sports doctor. I'm an orthopedic surgeon like Jason. We're not PM&R. We are orthopedic surgeons focused on athletes. And this is one of our athletes who had an ACL reconstruction. And you can see here just a 25-year-old who's still playing, and you can see the lateral compartment is degenerating over time. So again, status post-ACL reconstruction, what's happening? Well, I'd like to submit that every one of our patients who injures their knee, like you see Simone right there, a non-contact dynamic valgus injury creates a perfect storm, a catabolic injury. There's GAGs, MMPs, interleukins, growth factors all being released as Jason was talking about. The pericytes are coming off. They're being released. They're going to the zone of injury. There's injury to the bone, the cartilage. You have to consider all these variables. So it's a perfect storm from the transection of the ACL that leads to post-traumatic osteoarthritis. Hence the challenge for all of us. But let's look at this challenge. If we're looking at osteoarthritis in our population for men, you can see the type of prevalence of osteoarthritis. And for women, menopause causes it to deflect at that point, but that's the curve. But when you tear your ACL, look what happens. You fall off the curve between 20 and 35 years of age, like you see there. Those are our patients here and there. How do we manage them? How do we think about that going forward? The consequences of these injuries indicate a 7-fold greater likelihood of having this, a total knee replacement, at just years after the ACL injury. Our goal, all of our goals, everybody on the webinar tonight, Apex and us, to really focus on how do we disease modify? What's the secret sauce? Can we make a difference in the big scheme of things? And that's what we're talking about. And why? Again, data and details. The prevalence of post-traumatic osteoarthritis after ACL tears at 20 years is 40%, whether you do surgery or not. In addition, when we look at osteoarthritis, non-traumatic induced osteoarthritis, we can see here to the individual, it becomes the significant impact above 50, more than almost any other disease over time. And when you look at our population, when you look at the incidence of osteoarthritis from 2005, we are an exponential increasing number, as you can see, by 2040. So all of us are going to be busy taking care of osteoarthritis in one form or another. Because we're sports doctors, we became interested in this. This fellow right here, Ramon Cugat from Barcelona, got me interested in it. And in 2007, we started using this in our athlete population, further popularizing it at the Heinz Ward Super Bowl and Kobe Bryant. But here we are, focused on what we're going to do. In many ways, as we can see from Jeffrey Moore, he's given us the innovation diffusion curve. Just like any technology, we see that it starts with the innovators. Like we hear someone like Dr. Jason Dragoo and others on this webinar, Ariana and others. And then we have the early adopters, probably most of you, the visionaries. As we approach this, we can see it is really the point, the tipping point, that we then cross the chasm, as Jeffrey Moore calls it, and we get it to the early majority, late majority, and the laggers. So the innovation diffusion curve gives us an understanding of where we are going with orthobiologics for our future going forward. And we at Cedar-Sinai are in direct collaboration with a variety of programs around the country through the BARB, Biologic Association Registry Biorepository, with Mayo, with HHS, with Jason at Colorado, Cleveland Clinic, Stanford, Northwell. We are focused on trying to figure this out as our Regenerative Orthobiologics Center, leading to our biomanufacturing center that really develops induced pluripotential stem cells for cardiovascular, pulmonary, and other types of neurologic degenerative disorders. So we are really trying to figure out this concept, catabolism and anabolism. And looking at the joint, we have to understand all these details that go on, the crosstalk, the interaction between the bone, the cartilage, the synovium that leads to this progression of osteoarthritis. Well, we sit back in 2024 and we have a whole spectrum of things that we could use, a whole family of these. And asking ourselves as we scratch our head is, what is the ideal adjuvant combination? But first, we have to understand the principles. When we talk about tissue engineering, we have to understand it takes a trilogy. It takes cells, scaffolds, cytokines, and growth factors to impact. It's not just putting in one. It's not just putting in two. You've got to consider all of these things, and that's what I want to speak to. This is what Jason was really talking about. This niche, this pericyte, how do we stimulate it? How do we get to do what we want it to do? And we certainly know in medicine about adjuvant therapies. It's multi-components, multimodal approaches that enhance and improve the efficacy of those interventions. So let's talk a little bit about the whole spectrum. Mike Cicciotti gave us glucosamine, chondroitin sulfate, and raises the question of whether or not it can protect and delay an impact as a disease modifier going forward. Not proven, but some early evidence, especially in animals. HA has the last 25 years, lubrication. It creates a decreased inflammatory response, improving viscoelastic properties while it protects cartilage degeneration. And we have to know there's a big difference between high molecular weight and low molecular weight. Very different, as you can see, and in terms of getting to this very important, minimally clinically important improvements. High does, low doesn't. So we put all the data together, guess what happens? We lose efficacy. So we have to understand and explain that. How about the ABCs of PRP? And as Jason really talked about, we're talking about the PRP. We have to understand that there's a difference between the buffy coat and the plasma-based. Platelet concentration and white cell concentration is essential and important, and we'll talk to. And also activation and dosing become critical. And again, if you change any of those things, certainly things change over time. Now, as I said, I want you to leave with a concept. These processes between the MSCs and PRP are well orchestrated and biologically integrated. If we take MSCs from that pericyte, as you saw, PDGFBB, you release the pericyte, it becomes an MSC. They look at the PRP, they smell it, and they swim towards the PRP. They're attracted there. They're summoned, and when they get there, they proliferate. And when that occurs, it releases more of the growth factors and therefore having a positive effect on cartilage, metabolism, regeneration, synovium, the meniscus, and chondrocytes. Again, well orchestrated. We are just observing biology in action. It's amazing to see this and understand this because we, the clinician, have to, in many ways, reproduce that or try to get some therapeutic intervention going forward. Again, we look at PRP. We understand it's anabolic, it's anti-inflammatory. PRP stimulates cell proliferation, as you saw. It potentiates SOX9 transcription and elevates COL2A1 and ACAN expression, all of which targeting anabolic genes. If you look at the literature in terms of efficacy, we won't go into that, but there are all the articles showing efficacy. But the key things going forward is understanding there are nuances to take home. These important nuances, for example, it is essential to have in this article 10 billion platelets is crucial for PRP and the long sustained chondroprotective effect. Lots of plates are important. In the BAR project, as you can see on the left side, we learned that the responders have more platelets than the non-responders, statistically different. But we aren't the only ones who made the same observation. We could see in this chain of studies of that using the VAS score, high platelets in green, 3, 6, 12 months were associated with a better effect in terms of impacting the VAS. So high platelet numbers, the more, the better concept to take home. Activation. We know in this systematic review, activating with calcium chloride is more effective at improving pain and functional scores with NEOA, just using calcium chloride. How many of you are doing that now? Show of hands. Not many. I know that for a fact, but something to consider. How about having your patients on a bicycle? What does that do for the PRP they create? Well, Animance has shown 20 minutes of vigorous bicycle riding increase the concentrations by 20%. 20%. We do that in every one of our patients. We drive them to get on the bike before they give their sample and every day thereafter. So another important detail. How about using PRP and HA? What's the effect? Well, we know what happens here is that HA induces a release of more TGF-beta-1 and PDGF. Let's get back to what Jason told us. He told us that PDGF-BB stimulates more pericyte release than more MSCs. So your patients say, do we have a stem cell intervention? You betcha. You're getting at it from a different angle. These biological systems work in very specific ways. So what's the ideal adjuvant combination? We know from Brian Cole's systematic review meta-analysis that PRP and HA has a greater improvement than HA alone. So I want you to think about the combinations in detail. And this study done by João Espargaro Mendes from Porto, Portugal, when he was able to culturally expand bone marrow derived MSCs, it wasn't until he combined it with PRP that he saw the best response overall. Again, PRP and these expanded stem cells seem in green to have the best effect going forward. As we move forward back to the PPP, it's important to understand the relationship between A2M, which is found in the PPP. And the A2M is amazing. What it does is it soaks up the proteases, and then like a venous flytrap, will squeeze them and then release them out to the bloodstream after they've been broken down. The fascinating thing is that A2M decreases levels of MMP, all the MMPs, TNF alpha, and neutralizes interleukin-1 beta, but at the same time increases the expression of cartilage protective genes, as you see, COL1, type 2, MSAD4, and AGRICAN. So the battle we're fighting. And this is what we're doing in the lab today. This is right on the edge, right on the frontier, as Jason was talking about what they're doing. What we're doing is we're looking at the macrophages. See these orange things right here in the synovium? Those there are type 1 macrophage. They're inflammatory type. What do we want to do with those? We want to convert those to type 2 that are non-inflammatory. Just remember that. Red, orange, inflammatory, green, non-inflammatory, and therefore unweighting the catabolism to anabolism. So how are we doing that? Well, interestingly enough, induced pluripotential stem cells, we've learned from Yamanaka, who won the Nobel Prize in 2012, and we in our model of a rat transected ACL, what we do is we're going to make iPSCs for M2 macrophages and convert the M1s to the M2s. Then, as you can see this progression, we're going to give it back to the rat. Just as you see, the M2, well, as we call the IMACs. The IMAC2s are going to be back to the rat knee after transection, and we're going to look at how osteoarthritis and post-traumatic arthritis is prevented in progression. So what do we know? Post-traumatic OA is prevalent. OA is prevalent. It's increasing. It's a challenge for all of us to disease modify. We are focused on precision medicine. The devil is in the details, and it's important that we understand these complexities. It's about specificity of the biological system. Platelet concentrations north of 7 are important to get a chondroprotective effect. And sometimes we even need to dose these every 3 months, especially in some of our athletes. Remember that it's the adjuvant therapies can be synergistic to optimize the results in all of our patients. And remember, as you can see in this photograph, it's about these well-orchestrated biological systems. Look here, we can see the orca whale on one of our trips to Antarctica. It's the male spy hopping, trying to get these penguins. But over here is mom. And what this male is doing is going up on the ice, faking to the right, the penguins go to the left, and when they do so, the mom eats them every time. A well-orchestrated biological system. We observe, just like we do between the MSCs and the platelets, trying to optimize the care of our patients. Thank you.
Dr. Mandelbaum, thank you so much for sharing such invaluable information. I want to remind everyone participating that you can go ahead and drop some questions that you might have in the chat box, and then we can get to some of those at the end. So now I'd like to go ahead and introduce Dr. Ashu Goyle to take it away.
Great, thank you. Dr. Mandelbaum, that was great. Can you guys see my screen here?
Hey, Taylor, is there any questions here? Because I have to also go on to another meeting. Is there something so I don't interrupt the flow?
No, you're totally fine. I did go ahead and give you permission, Dr. Goyle, to share your screen, and Dr. Mandelbaum, we're gonna go ahead and get to the questions at the end, so don't worry. You don't need to worry about that.
Okie doke.
Thank you.
Ariana will take care of it. Great.
Okay. Let's see.
Bert, I think, can you stop sharing your screen? And then I think Dr. Goyle will be able to share his screen as well. Oh, perfect. Thank you, Bert. Good to see you, by the way.
Great to see you.
Is that working? Can you guys see my screen?
No, not yet.
Okay. Let's see. Apologies for the technical difficulties here. Let's see, view. Let's see. I'm not sure exactly how to do this.
So usually it's down at the bottom of the Zoom webinar. It's the green share screen button.
Oh, there we go. Got
There you
it.
go. And then you'll go ahead and just pick which screen you're going to share.
Right,
And it should be your you can either share your desktop or you can share your PowerPoint.
Yeah, 1 second. That's not it. How do I get
So what? Go ahead. Well, just keep looking. It's no problem. So Bert, that was really great. I have a question, and I'm wondering if you have some experience with using injections of either PRP or platelet-rich plasma just for more lumbar-based pain. Have you had some experience, or are you in your athletes? Have you had experience with that treatment modality?
Again, I'm mostly knee and what I do, but we have had athletes who've had treatment of facet issues, and I have worked with a variety of other clinicians who've had good success using it for discogenic pain. So the answer is yes.
Perfect. Well, I think what we'll do is let Dr. Goyle share his experience because this is what he does. So I'm excited to hear what his experience is.
A perfect introduction, and I also want to thank Apex for facilitating our efforts and Jason's effort in really developing some of these technologies that are helpful for us. And, you know, the one of the key reason how I got involved with Apex is really the concentrating capability of this. And it's changed for me. I think it's changed the whole approach to what we're doing. And I'm excited to hear Ashu's approach to transforming pain with regenerative medicine. So
Great. Thanks,
Take away.
guys. Hang on one second. I think I had it and then I lost it again. Hang on. Can you guys see my screen at all?
yes,
You can? You can see my slides?
yes,
Oh, fantastic.
there you go.
I don't see my slides though.
The first one's blank. Whatever it is, it's blank, but it's a gray background. There it is. That's your first slide.
Okay, great. Today I'll be talking about transforming pain management with regenerative medicine. For those of you who don't know me, I'm Ashu Goyle. I'm a double board certified anesthesiologist, interventional spine and pain specialist. I trained at Cleveland Clinic, did my anesthesia residency there, did a pain fellowship there. I've been in private practice for about 17 and a half years now. I started my own practice, integrated spine pain and wellness, 3.5 years ago, and I have a heavy emphasis on orthobiologic procedures of the spine. So today I'll be talking about some of the traditional pain management modalities that interventional spine practitioners like myself use to manage chronic low back pain and acute low back pain. We'll talk about some of the concerns with steroid use, some of the limitations of our conventional treatments. We're going to discuss regenerative medicine as a possible safer alternative to traditional pain management modalities. I'll discuss some of the research that has supports what we do. And then we'll discuss a couple of case studies and patient outcomes and best practices for regenerative medicine. And we'll go over some key takeaways. So as an interventional spine and pain specialist, low back pain is the most common thing I see in my practice. We perform epidural steroid injections to manage a lot of this pain. And after over 17 years, I've performed tens of thousands of these injections, including facet injections. That's how we manage facet mediated pain. We do medial branch nerve neurotomy, which is a technique that we can use radiofrequency energy to denervate the facet joints. For more complex spine cases, we can use neuromodulation, which includes dorsal root ganglion stimulation or peripheral nerve stimulation. There's also a newer modality, basivertebral nerve ablation, that's being used to treat vertebrogenic pain. And then we have trigger point injections for myofascial low back pain. Now, steroids are probably the absolute most common medication we use to manage pain with an interventional spine, in addition to local anesthetics. But there are concerns with long-term use of steroids, particularly risk of osteoporosis, immunosuppression, adrenal insufficiency. We know from repeated injections in joints that we can have degradation of cartilage. There have been hip studies that have shown that even one single injection of corticosteroid in a hip can lead to rapidly destructive hip disease in as soon as 3 months. So these are some of the concerns we have with steroid use. This study was published in Regional Anesthesia and Pain Medicine in 2021, and it was basically used to assess the rate of serious spinal adverse events following epidural steroid injections in Medicare patients from 2009 to 2015. What the authors found is that when epidural steroid injections are performed in this population, there was a really low risk of serious spinal adverse events. The risk was slightly higher in cervical and thoracic epidural steroid injections and lower in the lumbar population. They found no difference between corticosteroid formulation in terms of serious adverse events, meaning that particulate versus non-particulate doesn't carry any greater risk. And this is actually reassuring for those of us who do still perform these injections. So there's a relatively safe profile here. Now, this is a nationwide population-based cohort study out of Taiwan that was published in 2023 in Pain Physician. So this study evaluated the risk of osteoporosis associated with lumbar epidural steroid injections in patients with lumbar spondylosis. They looked at 4,957 patients who received epidural steroid injections and compared those to a control group of the same number who did not receive epidural steroid injections for lumbar spondylosis. What they found was that there was a 23% increased risk of osteoporosis in the epidural steroid injection population versus the patient population who did not undergo epidural steroid injections. So I bring this up because I think it's important as interventional spine physicians who perform these procedures regularly, we do need to have this as part of our informed consent. And many of us who perform orthobiologics of the spine, we have a separate informed consent specifically documenting the risks of steroids. This study was published in the Journal of Pharmacy Technology in December 2022, and is a comprehensive literature review, basically going over the long-term complications associated with corticosteroid therapy. Most of us are very familiar with this. The risks include avascular necrosis, GI bleeding, myocardial infarction, and cardiovascular events. There's high rates of diabetes, psychiatric syndromes, and susceptibility to infection. So these are all important points to also include in your informed consent for corticosteroid injections. Radiofrequency ablation is probably the second most common procedure we perform as interventional spine and pain physicians. And although it can be very beneficial, providing anywhere from 6 months to years of relief, there are associated what I call side effects as opposed to complications of these procedures. This study was published earlier this year in 2024, and it's titled Asymmetrical Atrophy of Paraspinous Muscles in Patients Undergoing Unilateral Lumbar Medial Branch Radiofrequency Neurotomy. This was a retrospective analysis where they took 24 patients who had experienced chronic low back pain. They underwent unilateral lumbar radiofrequency neurotomy to treat facet-mediated pain. They had MRIs assessed before and then 2 years after the procedure. What they found is that there was a significant increase in atrophy and fatty infiltration of the multifidus muscle on the treated side, and the untreated side showed little to no comparable degeneration. So they concluded that radiofrequency neurotomy may lead to long-term muscle degeneration, suggesting the need for caution and patient education on potential risks to their muscle health. Now, in my practice, I see a lot of spine patients, and I'm always talking about spine health. It's incredibly important to have a strong core, not just the abdominal muscles, but also the deep multifidus muscles, the iliocostalis muscles, the iliothoracic muscles, the gluteal muscles. All of those play a key, vital role in maintaining spine health. And if we do these procedures, we have to make our patients aware that we may actually be causing them harm long term. This is an MRI from a 28-year-old female who I saw just a few weeks ago. Her history is a 28-year-old female. She's a former professional soccer player, avid surfer, avid yogi. She developed low back pain in her early 20s. She underwent years of conservative treatment. And once she failed conservative treatment, she was seen at UCSD in their pain division, underwent an MRI study in 2021, which showed mild facet disease. They felt she was a good candidate for diagnostic medial branch nerve blocks, which is a precursor to the radiofrequency ablation. She had a positive diagnostic response, had the diagnostic injections repeated again, had a second diagnostic response, indicating that she would be a good candidate for a radiofrequency ablation procedure. So she had her first RFA and obtained 9 months of profound relief. And she told me that she had her life back. She got back to playing soccer, back to surfing, was doing yoga. But the pain came back at 9 months. So a decision was made to repeat the ablation. She had a repeat ablation. This time she got 6 months of relief, but it wasn't as profound of relief as her first ablation. So they repeated the ablation again. This time she obtained 3 months of relief. And again, this was not as profound of relief as she had had the first time around. She underwent a repeat ablation at 6 months. So for 3 months, she had no relief. Underwent a repeat ablation, and this time she had 2 weeks of relief. Follow-up MRI was performed in October 2024, and this is one of the axial images that I was able to pull up and use for a slide, but you can clearly see multifidi atrophy on the left side there. And now she's seeing me for potential orthobiologics. We're going to consider doing a functional spinal unit approach where we inject not only the facets, but also the ligaments, the surrounding joint capsules, muscles, particularly the multifidi muscle. So regenerative medicine, I feel, can be a potential safer for long-term benefit, and I'll be presenting some data to support this. And as an interventional spine and pain management specialist, I believe regenerative medicine is the future of pain management. Unlike steroids or radiofrequency ablation, orthobiologic treatments target the root cause of pain by potentially promoting tissue repair and healing, and also reducing pain and inflammation without the horrible side effects associated with steroids. So this study is a randomized controlled study that was published in 2020, and basically they took 50 patients. They randomized them to 2 groups. Corticosteroid group received 60 milligrams triamcinolone via caudal epidural injection. and the other group received leukocyte-rich PRP obtained from 60 mLs of autologous blood, again, administered under fluoroscopic guidance. They evaluated pain, quality of life at 1, 3, and 6 months. What they found is short-term relief was more significant in the corticosteroid group at 1 month. However, the leukocyte-rich PRP group showed superior pain relief at 3 and 6 months, as well as an improvement in quality of life via SF-36 forms at 6 months. No adverse effects were reported in either group, and they concluded that both treatments are effective, with leukocyte-rich PRP offering longer lasting relief and quality of life benefits, positioning it as a promising alternative to corticosteroids for chronic lumbar pain. And this is one of the conversations I have with my patients all the time when I'm offering treatments for lumbar pain. I include PRP right along with epidural steroid injections if indicated. This study was published in 2017, and it's another randomized controlled trial, steroids versus platelet-rich plasma, an ultrasound-guided sacroiliac joint injection for chronic low back pain. This was a prospective randomized study with 40 patients, 20 received PRP, and this was 3 mLs of PRP with calcium chloride. As Dr. Bert Mandelbaum was mentioning earlier, calcium chloride can activate the PRP, and we're seeing in the knee studies that this may be a superior form of PRP versus corticosteroid. They injected 60 milligrams of methylprednisolone with lidocaine. What they found is that the PRP patients had significantly greater pain relief at 6 weeks and at 3 months. 90% of the PRP patients experienced relief at 3 months versus 25% in the steroid group. Functional scores steadily improved with PRP, while steroid benefits declined after 4 weeks. And again, this is something I'm seeing clinically as well. I do several SI joint injections as part of my functional spinal unit approach, and I'm seeing the same thing where at 3 to 6 months, we have profound functional improvement and relief. This is a comparative study published in 2020, and it's titled Comparison of Intralaminar CT-Guided Epidural Platelet-Rich Plasma versus Steroid Injections in Patients with Lumbar Radicular Pain. They had an N of 60 with persistent lumbar radicular pain divided into 2 groups, 30 PRP, 30 corticosteroid. They did a double spin protocol, injected PRP under CT guidance, and measured VAS scores and function at baseline, 6 weeks, 12 weeks, and 24 weeks. What they found was that the PRP group showed significant leg pain reduction at 6 weeks, 12 weeks, and 24 weeks compared to steroids. Functionality improved significantly in the PRP group at 24 weeks. In both cases, no adverse events in either group. PRP displayed a favorable safety profile. These authors concluded that CT-guided PRP injections offer prolonged pain relief, functional improvement over steroids, suggesting PRP is a safer, more effective option for lumbar radicular pain with regenerative benefits and reduced steroid-related risks. This is another randomized controlled trial, platelet-rich plasma, epidural injection, and emerging strategy in lumbar disc herniation. This study had an N of 30. Patients were suffering from persistent lumbar radicular pain. They were randomly assigned to the PRP group or the steroid group. What they found was the PRP group showed significant improvement in leg pain at 6, 12, and 24 weeks compared to steroids. Disability index scores significantly improved at 24 weeks in the PRP group. No adverse events in either group. They concluded PRP provides prolonged pain relief and functional improvement compared to steroids, and is suggested as a safer and more effective alternative for lumbar disc herniation. These are 2 patients I've recently taken care of this year. Both underwent lumbar spine PRP procedures. The first one is a 53-year-old female, active, healthy person, enjoys pickleball, hiking. She's a world traveler, also a yogi. And she developed persistent back pain radiating to her hip and lower extremity. And this had been going on for about 3 years before she came to see me. She went through all the traditional pain management modalities, extensive physical therapy, epidural steroid injections, radiofrequency ablations, SI joint injections, SI joint denervation, but didn't obtain any lasting relief. So her physical therapist sent her to me to evaluate her for consideration of PRP. So after a detailed discussion, I emailed her my pre-procedure protocol, which is critical and vital to outcomes, I feel. And she committed to the program, and 7 days post-treatment after doing a functional spinal unit approach, she reported no pain in her hip for the first time in 3 years, her hip pain was gone. At 3 months, her leg pain and her low back pain had completely resolved. And she's back to traveling, back to playing pickleball, and back to hiking. Second patient I have is actually a friend of mine. He's an avid fisherman and a golfer. And he saw me at my last practice, and I took care of him performing epidural steroid injections and radiofrequency ablation procedures, did extensive physical therapy. He's very active, likes to stay fit. And when I started my new practice, he decided that after undergoing all these epidural injections and ablations, he wanted to try something different. And I presented him with the data. I felt he was a great candidate for PRP of his lumbar spine. So he followed my pre-procedure protocol, and we performed a functional spinal unit approach to his lumbar spine, injecting the epidural space, facet joints, facet capsules, interspinous ligaments, supraspinous ligaments, iliolumbar ligaments, all the sacroiliac ligaments, paraspinous muscles, hydrodissection of the thoracodorsal fascia, and within 2 weeks, his pain dropped significantly. 1 month later, he came back and he said he wanted his upper back treated because he was having some upper back pain. MRI showed some mild spondylosis. So we treated with epidural injections as well as facet injections. And 6 months later, he's back to playing golf and fishing, and has little to no discomfort. In fact, I just saw him at the gym a couple of weeks ago. He's lifting weights and said he was doing great. So when not to perform orthobiologic lumbar spine procedures, I think is just as important to know when to perform them. So anything that's surgical. So if you have an unstable fracture, spinal cord injury, spondylolisthesis with dynamic instability, radiculopathy with neurological deficits such as foot drop, myelopathy, cancer, or patient refusal, these are all reasons not to perform an orthobiologic procedure. So some takeaways. I think it's important to discuss all treatment options with patients. So if someone comes in with a herniated disc and lumbar radicular pain, I think it's important to not only offer, besides a conservative treatment, but from an interventional standpoint, epidural steroid injections, if indicated, but also consider PRP. We have data that's emerging that's showing that PRP may be a much safer and more beneficial option, especially for longer term relief. Always know when to refer to a surgeon. As interventional spine and pain specialists, our goal is to avoid surgical intervention if possible, but we are limited with our tools, and sometimes the pathology warrants surgical intervention. I think it's important to consider orthobiologics as a potential alternative to corticosteroids and radiofrequency ablations for the reasons we discussed earlier. There is growing evidence for orthobiologics in treatment of lumbar spine pain, but more research is definitely needed, specifically regarding platelet preparation, activated versus not activated. Do we include protein concentrate? I think all these are important. Platelet concentration, platelet dosing. As we've learned from numerous recent knee osteoarthritis studies, that platelet dose and platelet concentration is critical in generating a positive clinical outcome. And from Dr. Mandelbaum and Dr. Dragoo's work in the BARB, they're showing that platelet dose really matters, and non-responders may be non-responders because we're underdosing the platelets. So thank you, Apex Biologics. Thank you to all my mentors, Dr. Mandelbaum, Dr. Dragoo, Dr. DeMers. You all have been mentors to me throughout the years, and I'm grateful for you. And it's a pleasure and an honor to share this platform. If anyone wants to reach out to me, you can reach me via email, at my website, or on social media. I'm on Instagram, Dr. Ashu Goyle. That's probably the best way to get a hold of me. And with that, I'll pass it on to Dr. DeMers.
Thank you so much, Dr. Goyle. We appreciate the time you've taken to share your expertise on regenerative medicine and its instrumental role in your practice. We can now welcome Dr. Ariana DeMers to segue into the benefits and challenges of cash pay practice.
All right, guys, this is going to be the whirlwind tour because I really do want to get to all of your questions. There's great questions out there. So we are trying to be respectful of your time. There's just so much good information. So without further ado, I'm just going to share a little bit of how we might consider integrating into our current practice these orthobiologics. And so I'm just going to go ahead and share my screen. Okay, so here's what we're going to talk about today, and it's going to be the whirlwind, and we can always catch up a little bit later. But this is a step-by-step guide for structuring your practice from the ground up to build a successful cash-based micropractice to integrate alongside of your current practice. So what we'll have here is, as you all know, this is me. I'm a board certified orthopedic surgeon, sports medicine expert, and I do at least half to 3/4 of what I do is regenerative and orthobiologic medicine for my patients. So I just want to provide a clear roadmap for launching and growing a profitable micropractice based on orthobiologics. I'm just going to share this structure with you. So vision, team structure, efficiency, profitability, and the patient experience. First, you need to define your vision and your core values, what you stand for, what your practice brings, what guiding principles do you run your practice, patient-centered care, integrity, passion, flexibility, and then align your team to make sure you're all rowing in the same direction. Next, identify your ideal patient persona. You want to know who your ideal patient is, not only the patient that you love to serve, but that needs your help. And then understand those key pain points, understanding why they're coming to see you, what's motivating them to seek out your care for a cash-based practice. Just like Ashu talked about, they've been through the ringer, they've been through all of the standard care and they're not better. And so you have to understand why they're coming to you now and what you can do differently to help them achieve their goals and do goal-directed care. And then this allows you to have differentiation in the market to position your services to meet your patients' needs and desires. Next, you're going to build your core team. You have to have the right people in the right seats so that each team member aligns with your values and has very clear, defined roles. And you start with the seats, and then you go find the right people. And those right people have to get it, they have to want it, and they have to be capable to do the role that you're asking in them. So key roles for a micropractice include that physician, your patient care coordinator, administrative support, some sort of sales and marketing, which a lot of times either you can do social media or you can outsource. And then finance, you have to have somebody that can help you understand what you can and cannot afford and how to really leverage technology. And then you have an accountability chart that outlines those roles, responsibilities, and who reports to who for your team. Next, this is a really fun experience with your team to set a 10-year vision. Think long-term, what your reputation looks like, how far your reach is, how big your patient impact is. Then draw it back a little bit and say, okay, we're looking at 3-year goals. In the next 3 years, I want to be achieving these success milestones, patient volume, revenue targets, how many people you've helped. And then you can start to work on the 1-year plan and quarterly rocks or goals, measurable objectives that you're going to be going ahead and focusing on each corner so that it's each 90 days, you're working really, really, really succinctly to this goal. We're then going to talk about how you develop your efficient processes. You want to just standardize all of your key processes, document your workflow, start at the beginning of your patient journey. How do you do patient outreach? How do you do patient intake? How do you deliver care? How do you take money? How do you follow up? How do you organize your schedule efficiently and then document that? It's the 80-20 rule. Focus on documenting the essential 20% of the processes that achieve 80% of your results, such as how do you deliver your impeccable care? How do you do your patient outreach? And how do you do impeccable follow-up? And then streamline these processes. See if you can decrease the number of steps and increase your operational efficiencies. And then address these issues that come up, these recurring challenges, and there's going to be some, and really assess it with an agile mindset. Identify, discuss, and solve, and implement a framework to solve these issues, and so they don't keep coming up. And then create an issues list. We all have issues, but if you keep a running list of issues and you address them at your scheduled meetings, it stops you from becoming that fireman where you're always trying to put out these disaster fires, and you just put it on the list, shove it until your next scheduled meeting. working with building a cash flow positive practice, number one, I'm going to recommend that you use a profit first technique. Google it, check it out. It has been a game changer for both myself as well as a number of my colleagues. Next, you're going to implement systems for accurate billing, payment tracking, cash flow forecasting, and you're going to identify those services that are the drivers for revenue, such as subscription models, packages, orthobiologics, and then obviously running lean, minimizing that overhead. With regards to marketing and patient acquisition, you're going to be working on your patient persona. And so that when you reach out, you're not just hoping that somebody's going to find them. Those patients are going to feel like you were speaking directly to them, that you know them and you know that you can help them. And that will really help to build a targeted marketing approach. Additionally, building those relationships with your local healthcare practitioners, such as physical therapists, primary care physicians, will really help to kind of broaden that network, and they're going to continue to send you patients. And then engage these patients with educational material and services. Lastly, I want you to establish your meeting pulse. You have to conduct regular meetings, review your goals, discuss your challenges, align your team, and it has to be weekly. Use a structure that's efficient. Use a standardized format. This is based on the EOS, which is from the book Traction. And this keeps your meetings focused and efficient. And then every quarter, review those rocks or those goals and realign them as needed. So with proper structure, the team and the practice will flourish. Thank you so much. Now it's time to get to those ever so amazing questions. So if we want to go through these, Dr. Goyle, I think you probably have answers for all of these. I have answers for some of them. So I think if you can pick out some of the really heavy hitting ones, that would be great.
Let's see.
So I'm going to do one right now. When you do SI joint injections with PRP, do you use contrast to ensure your intra-articular injections? I do. I use dilute very small amounts. And there's studies that have shown that when you use dilute contrast, it does not appear to be harmful to the growth factors that you're using for the platelet-rich plasma. So you definitely want to know where you are.
Sorry.
No problem. The VisiPake. Dilute VisiPake is what I'm using. Mm-hmm.
Okay. I use
There's another question. Yeah. I think that the dilute is a really important part of that. There's another question here, just in respect of time. How much PRP volume is used for the facet joint and in the epidural space? And so I think you can go ahead and talk about your experience, caudal versus TFE versus interlam.
Yeah, so for a caudal epidural, I'm doing relatively high volumes, so anywhere from 15 to 25 cc's, depending on what level I want to reach. But I'm also doing interlaminars. With an interlaminar, I'm using 5 to 7 cc's. A transforaminal, I'm using about 3 cc's. Inside the facets, I'll inject about a cc. It just depends on what the facet can hold. So once I feel resistance, I back off, and then I'll just pepper the capsule with PRP. So that could be 1 to 2 to maybe 3 cc's, just depending on where you are. In the cervical spine, it's a lot lower volume, but I think we're focusing on lumbar here. So hopefully that answers your questions.
Absolutely. And then from a frequency of injection and duration, I think this is something that interventional pain physicians are going to have to change their mindset a little bit about. How many repeat customers are you getting from your PRP injection-based customers for a functional spinal unit?
Very few, to be honest with you. So typically, I mean, the results can take 3 to 6 months. So that's something I set my patients up for. This is not a quick fix. I mean, especially when we're treating chronic degenerative changes, right? They might get better, but we can see the result improve over the 3 to 6 months. And even beyond that, I've had patients turn the corner at 8 months and say, wow, my back is profoundly better for the first time in years. So my protocol is typically do the procedure, follow them over the next 6 months, reevaluate it 6 months, and then decide if we need to do something. If they're continuing to improve, or if they've plateaued, I just leave them where they are, and then we see how they do over the next 6 months. The only patients I've had to repeat were people who had more advanced pathology, like advanced degenerative disc disease, advanced spinal stenosis. They're not surgical candidates, so this is the only option they have. But even those I'm repeating maybe once every 1 to 2 years.
Yeah, absolutely. I think that's a great part of the education process is telling them when they can expect it, what to do. I know I see all my patients back at 8 weeks and I tell them, hey, this is very early. This is to just make sure you're on the right trajectory, make sure that we don't need to add something like therapy or some other thing, or take something away, like you're doing way too much and you need to rein it in. So that's really great. There has been some discussion that maybe a repeat epidural at 6 months may really supercharge that time frame. But otherwise, absolutely, I think, from a volume base as far as frequency based, I think that's been my experience as well. Okay, there's some other so there's a question from me. From my local practitioner referral sources know me as an insurance acceptor. How do I change my mold to a cash only based provider without making them upset? Well, so here's the deal: is you don't have to do either or. You can start out and check your lowest payers and say, okay, maybe we'll get rid of those payers, and in the space that's left behind, you start to bring in your cash based services. And then as you continue to reassess your payer mix, then you take off the next lowest paying insurance company that's paying you peanuts, and then that provides space in your practice to be able to accommodate cash-based procedures. I don't think you have to go all or none. You can do this stepwise approach, and then you'll become known as this hybrid practice.
Thank you so much.
Okay.
Thank you so much, Dr. DeMers and the rest of our panelists. We really, appreciate all of your guys' insights. We did have so many great questions, but in order to respect everybody's time, we're going to go ahead and, get closed up. So again, I just want to thank everyone that was able to attend this evening. We did want to announce that we are now offering monthly cadaver labs for MFAT, lipoaspirate, and bone marrow harvesting, as well as PRP and protein concentrate. This is a fantastic opportunity to experience these advanced technologies from Dr. DeMers. And best of all, there is no charge for the seminar. We just ask that you give us your RSVP within a week's notice of your desired attendance date. So moving forward, with that being said, thank you so much to our panelists. We are so grateful to have such experienced speakers sharing their knowledge and insights on these topics. Dr. Goyle, Dr. Mandelbaum, Dr. Dragoo, Dr. DeMers, thank you so much. And another thank you to everyone who was able to be present tonight on this call and make this such an interactive session. If you are interested in learning more about our products, please take a moment to scan the QR code on the screen. We will ensure that a member of our clinical education team gets connected with you to the best scheduled time to provide the necessary equipment and come for a patient trial and training on our system. So with that being said, thank you again to everybody, and I hope you guys all enjoyed this presentation and have a great night.
All right, thank you. Good night.
Thanks so much.